Evaluation of hyponatremia. There's all different ways to do it. This one is kind of the easier of it. There's only one really hard part of it. Well, first you get the serum osmolarity, okay? And if it's elevated, you need to start looking at, hey, hyperglycemia? Are we getting hypertonic infusions, glucose mannitol? If and then if it's normal, we have hyperlipidemia, so you could get a lipid panel. Look at the proteins and look at your sugars. Okay. Now, if it's low, this is when you have to do this is the part can be hard. It's sometimes very, very hard. I know in boards it seems like it's super easy to measure somebody's volume status. This is the holy grail. This is one of the hardest parts in doing bedside management is what's the volume status, especially in somebody who's super obese. What's their volume? It's really hard to tell. You could try with ultrasound and there's studies, and sometimes it doesn't work as well. And you have to kind of figure out what's my volume status. So if you feel they're isometric, we're going to say, or isovolemic, and we're going to say SIDH, or look at the SIDH. Or it could be psychogenic polydipsia, and these are things you need to work through. If it's hypervolemic, okay, now we need to look at CHF, maybe we can get a BNP, nephrotic syndrome or cirrhosis, or hypovolemic. Then we can measure the urine sodium. Okay, if the urine sodium is low, maybe we're having extrarenal losses. If the urine sodium is high, diuretics, adrenal insufficiency, salt wasting nephritis. Hyponatremia. Serum sodium concentration, we're going to say less than 135 milliequivalents, is most often results from increase in circulating ADH in response to true or sense reduction in effective arterial volume, thus causing volume reduction. Well, let's go back. We talked about in the beginning is ADH. So here we have our collecting duct. Okay. And here's P. It's gone through all kind of the gauntlets of the nephron. And it's getting ready. It's in the collecting duct and it's getting ready to be excreted out. And then we have ADH. ADH is always drilling holes. Okay. So it's drilling holes in the collecting duct. And you're getting free water is being extracted from the P, about to be P, and it gets put in there. So you're peeing out more solutes. So you can measure as a urine osmolar gap, and you use the measure the plasma and urine osmolarity and assessment with volume status. These are things that we can do. And we'll talk about the labs we need to order. So what's the side effects? Headaches, nausea, vomiting, altered mental status, weakness, falls, seizures. The neurons can have problems. They can work as well. They can be obtunded, or you can even have herniation of your brain can result from hyponatremia. You can get where you have cerebral edema from this. Osteoporosis it can happen because sodium is removed from the bones to maintain serum sodium over long periods of time. Now we'll have our continued discussion on hyponatremia. Now we've measured the serum osmolars, all right, and we've noticed we have hyperosmolar hyponatremia. So hyperosmolar, and we're going to say make it easy, is greater than 290. Okay, so our osmolars are greater than 290. We measured these. Okay, it results in an elevated plasma glucose or solutes such as mannitol or sucrose. So once you start seeing this hyperosmolar hyponatremia, you start to figure out why. And you look at your plasma glucose, or you can look at are you giving what kind of solids are you giving? When do you give mannitol? You can give mannitol for cerebral edema. And then you can try to do a correction for the sodium for glucose correction. This is if you have hyperglycemia. And let's get an example. We'll kind of calculate it out. You can follow along, or you can go to MD Calc. They have a nice calculator. Now, let's say, for example, we have where we're measured were 120 serum sodium, but our glucose is 800. Our glucose is 800. And the way we measure it is we take 100, greater than 100, greater than baseline. And then so in this case, it'd be 7. And we're going to times it times 1.6. And then there's another we can do is between 2.4. You can use either one of these, or I like to do is kind of get the medium between the two. And then at 1.6, so 7 times 1.6 is going to be 11.2. and we add this to the 120, and we get 131. Okay, this would be on the low end. Now on the 7 times 2.4, we're going to get 16.8. And then we add to this to the 120, and we're going to get 137. So between those numbers, we're going to say is ideally is going to be what our corrected serum sodium is. So we look at it, oh my gosh, we're low at 120, but all this glucose is displaced in the measurement, has replaced the measurement of serum sodium. And between those two, this is a corrected number. Neither one is going to say is perfect. You can use the average of the both of them, or kind of look at each one and kind of feel which one do you feel is correct. So the patient we thought is very low, and either they're going to be normal or they're going to be just slightly low. Pseudohyponatremia is a normal osmolar hyponatremia, and the laboratory error in measurement of serum sodium is due to extreme hyperlipidemia or hyperproteinemia. So hyperlipidemia can cause us, or hyperproteinemia can cause us to have these errors in our measurement. Hyponatremia, this can be broken down into 3 types based on clinical volume assessment. Hypovolemic, hypotonic, hyponatremia. We can have hypovolemic, hypotonic, hyponatremia. Euvolemic, hypotonic, hyponatremia. And we'll discuss each one of these. So it's either going to be the volume status is going to be low or normal or have more volume than they should based off of assessment. And this is the hard part, getting this assessment correct. Now let's talk about hypovolemic hyponatremia, hypotonic hyponatremia. Okay, so hypovolemic, okay, let's break this down. Low body volume, hypertonic. So we're going to say our serum osmolars are going to be less than 290. Hyponatremia is stimulation of the renin-angiotensin-aldosterone axis and release of ADH due to low volume status at the expansion of serum sodium with excess water intake. Extrarenal causes of hypovolemic states include sodium loss from GI tract, nausea and vomiting, and insatiable loss from chloride from sweat, burns, respiratory tract. Your urine sodium will be usually less than 20. Milliequivalents. Hypovolemic, hypotonic hyponatremia. Hypervolemic, so you're going to be volume overloaded. Hypertonic, meaning that serum sodium is going to be greater than 290. You have increased total body sodium and water, with the water being more dominant, causing a dilution of effective sodium. When you have this, heart failure, CHF, cirrhosis is famous for this. Nephrotic syndrome is a kidney census, decreased arterial blood volume despite excess total body water. Urine sodium is going to be typically less than 20. And then you can have acute or chronic kidney disease, inability to manage both sodium and water. You'll have the urine sodium will be greater than 20. So in kidney disease, you don't have the ability to manage sodium or water properly. Euvolemic, meaning the volume is normal. Hypotonic, meaning that's less than 290. Hyponatremia, urine sodium is usually greater than 20. We're going to say 40. Just the reason why is it just makes it easier to diagnose SIDH. Is the most common cause. So SIDH is the most common, but you need to exclude hypothyroidism and glucocorticoids. So what do? You get a TSH, and you can get a random cortisol. Patients with hyponatremia and an elevated urine osmolar mean that inappropriate ADH concentrating urine. So remember, always drilling holes. Treatment fluid restriction without limiting sodium intake. If no response, consider giving a loop diuretic combined with oral sodium supplements. Tolvaptan and conivaptan are effective in normalizing hypernatremia, but it's only those who have failed optimized medical treatment and with a serum sodium less than 120. They are expensive. Okay. You need to be careful in those with liver failure. On these, the trick is you do not withhold fluids. Okay. They have to drink normal amount. These can be violent. I just want you to know is that you can have an uber correction on these. They need to be taking and they need to be drinking fluids. These can be violent, they're expensive, and they don't improve morbidity and mortality. They make the numbers look good. Management and treatment hyponatremia. Rate of correction of serum sodium must be considered to avoid osmotic demyelination syndrome. That's where you melt the ponds. You've been seen in rapid correction greater than 8. The numbers, it keeps getting lower. I think you're going to start seeing this 4 to 6 in a 24-hour period. It used to be 12, and it's really dropping. So you can say right now a 6 to 8 is safe, but it may drop to 4 to 6. 12, that's old school, it goes away with greater than 60 milliequivalents within the first 48 hours. This is this is you'll people say the incidents are low, but it's very easy to see. It's very easy to prove because you have the numbers. You're going to have the numbers in your system, and then all you got to do is get imaging or you show clinical decline, and this is basically you're going to write a check. If overcorrection occurs, you can get desmopressin or IV dextrose 5% or free water if they can take things orally till the sodium numbers get lower again. You melt the ponds. You melt the ponds. Osmotic demyelinating syndrome usually affects the pons and presents days after overcorrection with paralysis, dysphagia, dysarthria, dyslopia, and locked-in syndrome, along with possible loss of consciousness. If you look around in your hospital systems, you probably have somebody who they've had an overcorrection and they just keep coming back. I've seen these, and the only reason that these people are alive is due to their family members' persistent making sure that these patients are taken care of. And it's one of those things. Remember, first to no harm is so we can cause harm with somebody. It's very easy to measure. It's very easy to be a check writing event, and one of those things that you'll have sleepless nights because you harm somebody. All right, SIADH. This is going to be your main one for hyponatremia. When the kidneys perceive they are dry, they retain sodium. And usually urine sodium is greater than, you'll see 20 to 40, but really the average is going to be 70 to 80. 70 to 80 is a good number. 20, less than 20, no. 20 to 40, meep, may or may not. Above 40, yes. 70 to 80, great. You know for sure you got a diagnosis. You have low sodium. You have normal volume. Uric acid is low in most cases, unless there's an underlying gout or some other problem. You need to check the urine sodium, urine osmol. Lowest urine osmol is 50 to 100. If urine osmol is greater than 100, so urine osmol greater than 100, you're going to have SIDH. Treatment fluid restriction. Review your medications. SSRI, carbamazepine, pregabalin, phenytoin, valproic acid, haloperidol, cyclosporamate. And then you can also give as a treatment. You need to hold these review for holding these medications. Sometimes you can't. Sometimes these are very important, like carbamazepine. Sometimes you can't stop that. So furosemide is going to increase the serum sodium by inhibiting the reabsorption of water. It inhibits the reabsorption of sodium. Loop diuretics can raise the serum sodium. Now, we talked about it before, tolvaptan and conivaptan. Yes, they can be used. They make the numbers better, but they can be violent. Remember, the tip, you do not hold water with these. These will increase it violently, and sometimes you can see the correction can be an uber correction, and you have to recorrect it. Go low on the dosing if you're going to do it, and be very careful. This needs to be in an ICU setting in most hospitals. This is where you should do it. SIDH is having the problem of absorbing too much water. We talked about this, and I'm going to keep talking about it. Is urine, you're collecting tubule. This is urine, and it's pee-pee, and it's waiting to come out and go outside the body. But here, we're always drilling holes in the collecting tubule. This is the last part of the gauntlet the urine goes through. And the solute is excreting, so that way you're pulling more water, more free water into all your tubes. SIADH, it's not the easiest thing in the world to treat. You can have patients in there and you're doing fluid restriction and you cannot get that sodium to budge. There's some treatments you can try, oral urea. It's a medical food, okay? And I don't know if patients are going to really love this when they figure out what it is. Well, what do you think it is? And it can cause osmotic diuresis, leading to free water excretion. It works in studies. Probably doesn't taste the greatest. And once patients kind of figure out what that is, dried urine, that they may not love it. Okay, there's a first formula, and this can help us determine if fluid restriction is going to respond. And it's a urine to plasma electrolyte ratio, a method to determine whether a patient will respond to fluid restriction. And if the urine sodium plus urine potassium divided by serum sodium is less than 1, then the patient is excreting for free water and likely respond to fluid restriction. If the ratio is greater than 1, the patient is unlikely to respond to further fluid restriction. If ratio greater than 1 and serum osmolar less than 500, you can give urea. We talked about this. 15 grams POBID. If urine osmolar greater than 500, urea 30 grams POBID can be administered. Now, once it's determined that we need to give more solutes in our hyponatremia management, what are some things we can give? The big ones are salt tablets, urea, and protein supplements is starting to turn the corner is possibly one of the answers. So you can get a 5.2 milliequivalent improvement in serum sodium after about 48 hours. Now, the common dose is 2 grams CID, and that's way too low. You only get about 200 milliosmolars of solute, of dissolved solute in those. So really the dose should be 15 grams. That's quite a lot. Those are 1 gram sodium chloride tablets. So those 15 of those, and it's kind of hard to get patients comply with that. Urea is making an up and coming statement, and there's some problems with it. First of all, it's a medical food, not FDA approved. And your insurance usually won't cover it because it's considered a medical food, not an FDA approved thing. And also, it tastes like pee. So not a lot of people are going to enjoy the flavor of pee. It increases free water excretion. It has a higher solute load than salt tabs. 50 milliosmolars from 30 grams of urea equal to 15 1 gram sodium chloride tablets. So this 30 grams of urea, it can be 2 dissolvable packets, 2 packets that dissolve. There are some reports that urea being expensive. And here again, it's probably not going to be covered by your medical insurance. Now, protein supplements is kind of an out-of-the-box thing. It's going to cause us to increase our urea. It's going to release for urea. And it's the same theory as urea. It's cheap. You can get it anywhere. I mean, it's going to taste better. There's all different formulas, and you would get kind of a pure protein powder. And that should increase the amount of solutes. Kind of same thing as urea should cause free water excretion. There's not going to be any studies on it. And it'd be a heck of a lot cheaper. And I'm sure it's going to taste better than what urea tastes like. Now let's talk about loop diuretics and hyponatremia management. It inhibits the sodium potassium 2 chloride channel in the thick ascending loop of Henle. It's going to disrupt the medullary gradient. It takes away ADH's ability to reabsorb free water. So you're going to pee free water. Now it's recommended you give a solute. You can give salt tabs. We discussed urea, and possibly protein powder can be also given. Now, this is something that's not discussed a lot, but it can be a helpful tool to predict response to fluid restriction in SIADH. The urine plasma electrolyte ratio. So if the ratio is 1, this is getting the urine sodium, the plasma sodium, urine sodium divided by plasma sodium. There will be no response. No response to fluid restrictions. Now remember, fluid restrictions, they're hated by our patients. That's one of the things, like if you're managing somebody on the wards, and you're having to go through and restrict their fluids, that's the first thing they're going to ask you. That's the first thing they ask nursing. How much can I drink? How much have I drinking already? Is there a way I can get more water? I'm thirsty. I'm thirsty. I'm thirsty. So if we're going to do this, if we're going to restrict fluids and it doesn't work, we're going to lose credibility from our patients. Now, if our ratio of urine to plasma electrolyte ratio is greater than 1, you're going to need an additional therapy, something to add on, maybe a loop diuretic, maybe salt taps. Now, if the urine to plasma electrolyte ratio is less than 1, fluid restriction should work. Now, is this perfect? No, there's some research behind it, but it's a tool to help us figure out what is going to be the best way of management for our patients. Hyponatremia after endurance events. This is a big thing, and it seems to affect women more than men. After endurance events, athletes, due to the ingestions of large amounts of fluid, of hypotonic fluids during the event, they're drinking a lot of water. You see this more with bikers than marathoners. Bikers, because they can have those packs on their back and they can ingest large amounts of fluid. It's really causes secondary to release of vasopressin, results in renal water retention. Low levels of sodium can develop cerebral edema, seizures, coma, and possible death. Treatment: hold fluids if mild, if severe, hypertonic saline. Hypernatremia post-op. Post-op hypernatremia can develop due to release of vasopressin related to surgical stress. Vasopressin loves to get released. Any type of stress, your body releases it. Even pain will do it. Or hypotonic fluids given during surgery. Risk of overcorrecting a rapid intermittent bolus versus slow continuous infusion therapies of hypertonic saline with patients with symptomatic hyponatremia. All right, in this discussion, now there's different ways you can correct hyponatremia, and you can use hypertonic saline, and usually it's 3% saline, and you can do continuous, and it's usually like 15 to as high as 45, and you do it slowly. Or if someone is less than 120 and you're having signs of seizure, you can do boluses, less than 120 usually, and it's usually 100 milliliters of 3% over 10 minutes. And you can give 3 boluses of this, usually. And your goal is to get from, say, your 115, and you really want to get over that kind of that magic number of 120. You want to get that number so you're 5, and then you want to hold off because you don't want to get greater than 6 to 8 still. And hopefully when you get them over that 120, you're getting some of these symptoms are going away. And you can do these boluses. Now, they really showed no difference in overcorrection risk. However, the rapid intermittent bolus had a lower incidence of therapeutic relowering treatment, meaning that you were able to get to your number and you didn't have to correct your overcorrection. You didn't have to correct your overcorrection. And this is for serum sodiums of 125 millimolars or less. These are things to think about. So remember, in correction of your serum sodium being hyponatremic and they're symptomatic, you want to do a 3% usually. Now you can do slow, which is be 15 to 30, maybe 45. And you check it every 4 hours. Some people do it every 6 hours. 15 to 45. You check it every 4 to 6 hours. Or you can do these boluses, and the boluses are 100 over 10 minutes. And usually you do about 3. And your goal is to get over that magic number, usually is 120. And remember, you still have to watch your overcorrection.